Hi, this is David Snopoliski, one of the co-editors on the Fits on the Go blog. I am pleased to be here with Dr. Webb from the University of British Columbia. Dr. Webb is actually one of the pioneers of the TAVR procedure. Thank you so much for joining us today.
Thank you.
Dr. Webb, can you please talk to us about what went into the development of this procedure and how things came about?
So people have been thinking about this for a long time, and the first animal implants of TAVR-like valves were back in 1992. The first successful implant in a human was in France in 2002. That was a transeptal procedure, and the procedure really couldn't be replicated reliably. I guess we're known for having developed the transfemoral transarterial procedure, which was really the first repeatedly successful and repeatable, reproducible procedure.
That's quite interesting. And the procedure today, how does it compare to how things were in the past? Have you seen a lot of changes or developments over the years?
Well, there was a massive learning curve. Early on, we had a poor understanding of how to access the aortic valve from the femoral artery. There were a lot of vascular issues. We had no idea how to position the valve in the aortic annulus, how to size it. And so there's a huge learning curve for about 5 years. After initial feasibility, it was really only appropriate for patients who absolutely could never have surgery. It was something we could offer. It's still very high risk, but it's changed massively over the last 5 years, particularly where it can be done reproducibly, large numbers, and I think you can arguably say that the majority of patients would do better with the TAVR procedure than with surgery. That would be controversial, but that's the position many of us would take.
And from a procedural aspect, do you see that there'll be many changes coming up in the future in how we do the procedure?
I think just over the last few years, it's evolved from being a cut down on the femoral artery to a fully percutaneous procedure in and out. It's evolved from being a procedure that routinely required a general anesthetic, intubation, and esophageal echo to the point where most patients are being done, at least in other countries, awake under local anesthesia. It's evolved from being a procedure that kept you in hospital for 2 weeks to one where you may well leave the next day after you've had your valve implanted.
And in the future, from a TAVR perspective, what type of patient population would you see TAVR commonly used on? I know now it's more of a select population, but hypothetically in 5-10 years down the line, where do you see things going?
Well, I think arguably with the PARTNER 2 trial today, it's clear that the transfemoral procedure is non-inferior, if not superior, to surgery in intermediate risk patients. And if you look at the newer results with the somewhat lower profile SAPIEN 3 system, that's dramatically better than even in PARTNER 2. So I think we're looking at a procedure where high risk, intermediate risk, and low risk patients will have a lot of advantages with the transcatheter procedure. Currently, you can argue maybe we've not enough evidence for low risk patients, but I would argue that we do.
That's interesting. I'm very curious to see what happens in 5-10 years down the line. It seems like this is going to be a procedure that's really open to most candidates. So that'll be quite interesting to see what comes about. Well, thank you again for joining us today. Again, here with Dr. Webb, the pioneer practically of the TAVR procedure. For more videos like this, please join us at www.youtube.com/fitsonthego.